So we do want to thank everyone for joining today's workshops and for your generous donations. We've raised over $1,500 on this workshop. So deep, deep thanks to you for supporting our mission. All of today's proceeds will support people of color to train in the Alexander Technique through the Judith Leibowitz Scholarship Fund. And today's workshop will be recorded and shared with donors who were not able to attend. The fund provides 50% of tuition to a training course at the American Society for the Alexander Technique. We're currently supporting trainees in Los Angeles, New York, Albuquerque, and Chicago. The committee of the Judith Leibowitz Scholarship Fund sees Alexander Technique in the 21st century as a tool for anti-racism. We support the continuous efforts to unveil racism and any forms of oppression in the work, the writings, and the institutions of the Alexander Technique. For today's workshop, there will be an additional 15 minutes added on. So from 3 until 3:15, there's going to be a Q&A. So feel free to put your questions in the chat. And then as Jack finishes his presentation, we'll segue over to the Q&A and we'll be looking through the chat to ask those questions of Jack. And now for a very special introduction, I'm going to pass the mic over to the infamous, the lovely, the magnificent Judy Stern.
It's really special to be here today and really special to support this dream of Jessica Wolf. So I'm just going to jump in and tell you that Jack is my husband. He's a neurological surgeon. We met in 1984, just as I was starting my training in the Alexander Technique. And he has been an amazing supporter of this work, both at ACAT and AMSAT throughout the years. He's lectured to raise money at ACAT. He's lectured at 2 international congresses. And the thing that he did first, before I was even finished my training, was he helped Deborah Kaplan write this book. And Debbie, Jack, and I sat in this house and put together the chapters of this book. And if any of you have ever seen it, you'll know that he wrote the foreword. And in the foreword, what he says is that this is undoubtedly the best way to care for the back and alleviate back pain. The Alexander Technique stresses unification in an era of greater and greater medical specialization. It enables patients with back trouble to get better, faster, and stay better longer. Jack, it's all yours.
Thank you. And thanks to you, Rebecca and Renee, and a particular thank you to Jessica Wolf. I remember a few years ago when Jessica brought forward this idea, and I just thought it was a wonderful idea to expand those practitioners of the Alexander Technique and create what is today called diversity, equity, and inclusion. And of course, to honor Judy Leibowitz, whom I knew, and as someone who is reaching the end of my career, I understand how important it is to honor those upon whose shoulders we saw the horizon. And Judy Leibowitz was certainly one of those amazing individuals, amazing as a human being and as an Alexander teacher. So I'm honored to be here today. So let me start sharing my screen. PowerPoint presentation, share. So I hope you can, so that's me on the left in my normal garb. Having been a neurosurgeon for 40 years and with a specialization in the last 10 plus years in the spine. And that's how I spend my day. But as Judy said, about 30 years ago, next slide. about 30 years ago, very much through Judy, I started reading extensively in the works of Mr. Alexander, and was really taken with the insights of this gentleman, and began to be very serious about trying to think deeply about how this technique might have application in my own area of specialization, and that is back pain. And so the title of my talk today is there a role for the Alexander technique in the treatment of low back pain? Which is essentially what I've been thinking about for many years on and off in a variety of different ways. Some very clinical, as in this talk, and some, if you've been to the last Congress, where I talked about the brain and how pain is encoded in the brain, and how the brain can change with Alexander lessons, which is really an amazing. When I did that research, it was amazing. It was highly theoretical, and now many others are starting to think in many other ways about how the brain, which we always consider as inalterable, you got those neurons, that's what you got, that's what you're left with, you kill them, and and they're gone. And we find out now that that is not the case. There's tremendous plasticity, and the plasticity of the brain includes techniques like the Alexander technique, and we can go over that some other day. But from a clinical point of view, is there a role? And I would tell you that it is not whether the Alexander technique is effective in treating low back pain. The question is, and why is it not being used more? Why has, in my career, 20 years ago, hardly anybody heard of Pilates. Hardly anybody heard of Feldenkrais. And yet, I see patients every day, maybe that's an exaggeration, but certainly once a week, who come to me and say, I did well with Feldenkrais, I did well with Pilates. Chiropractic has become so mainstream that one doesn't even consider it as an alternative therapy. So the question, as I pose it, is why it's not used more as a primary treatment for low back pain. And essentially, in order to look at this a little bit more critically, I would say there have been several articles in peer-reviewed journals that support this. This is the one on the Alex, and this is not only today, this goes back 10, 15 years already. So it's not as if we're looking for scientific evidence. Much of the evidence already exists. This one is by Ernst and Cantor in the Alexander Technique, a systemic review of controlled clinical studies. And if anyone is interested, I can always send you the references. This is actually an abstract of that article. And this was written in 2003, 18 years ago. And the conclusion there was a few controlled clinical trials of the Alexander technique yield encouraging, albeit not convincing evidence, and it needs to be studied more. And in fact, perhaps the most prominent article in the most prestigious British journal, which was, and I'm sure most of you know this, was published only, 5 years later, and where there was a randomized control study of the Alexander technique for chronic recurrent pain, which showed true efficacy. And yet the community in general has not really picked up on it. And so what I needed to do was think more deeply about why that is, because I'm always looking for modalities that will help my patients. I mean, such a small percentage of my patients need surgery, so I'm looking for other alternatives. And I realized that, now this list could be longer, but just to give you a summary, I better look at my watch. The first thing I'm going to do is I'm going to go through these slides rather quickly. That is to appreciate the size of the problem. I bet there's not a single person amongst you who doesn't know several people who have back pain. So you'd like to appreciate the size of the problem. I'm going to try at the end, and maybe that's a topic for another lecture. Whoops, is to have a basic understanding of spine anatomy and physiology, and to be able to identify the primary pain syndromes associated with low back pain. And then the latter is to identify those individuals with possible underlying medical problems. I happen to think that number 4 is very important. Why? Because I think there's a reluctance, even amongst physicians, I see this all the time, who don't want to treat back pain because they're concerned that it's not back pain. It's actually something serious that requires significant medical attention. Oh, I didn't know I could do this. So this is probably a key slide. And that is, it's a major health problem. And I'll show you in a few minutes some of the statistics, some of them going back to the late 90s and some that I just was able to get this year. But what's interesting is that most low back pain, greater than 90% of low back pain, is related to poor use. Now, if that isn't within the realm of the Alexander technique, I don't know what is. Whoops. I'm sorry why this isn't coming up. Oh, because I got to do that. So this is from 1998, and I pulled out these slides because the statistics, as I looked them up recently, haven't changed. And that is almost 29% of adult population had back pain at some time during this survey in Saskatchewan. 50% reported low intensity, low disability within the previous 6 months. 12+% reported high intensity, low disability. And 11% had been disabled by low back pain in the previous 6 months. This was a study done, they randomly called people on the telephone, random. And these were the numbers in 1998. These are the numbers in 2012. And as most of us know, 85% have low back pain at sometime in our lives. Now, to review some of the data from 2021, low back pain is the leading cause of disability for people under 45 years of age. It's the second leading cause of visits to doctors' offices. I bet you that you wouldn't have guessed that. All right. And the annual cost of low back pain is greater than $100 billion per year in the United States. That's a big, compared to what our present president wants to spend, it's not $1 trillion, but this is a lot of money. This is a lot of money that could be used for other things. So just to go over, this is 202, another study that shows that back problems were the top leading cause of lost work days. I'm just going to quickly run through these because I think unless one understands how significant the issue is, you might not appreciate how big a population of people there are who might benefit from the Alexander technique. This is not a rare problem. This is a common problem. So the 10 most costly conditions in the United States in terms of direct medical costs, number 6 was low back pain, days in bed, back problems, and this is also interesting. Failure, when asked to rank failure to receive an adequate explanation for a problem and dissatisfaction amongst patients treated for low back pain, the first disease, when folks were asked, well, you went to the doctor, how happy were you with the diagnosis and the treatment? the folks who were most dissatisfied were individuals with low back pain. Okay, and we just went through the others, and I would say as an aside, some of you know that I wrote this book called Ending Back Pain, and one of the reasons I wrote that book was because the issues that I raise here. Number one, most individuals who have back pain don't know why they have back pain and are usually dissatisfied by the fact that they have back pain. The fact that the surgery rates in the United States have increased by 55% for conditions of low back pain. And it's the number one cause of disability amongst individuals 45 or younger or older. And this is 1% of our population at any given time is temporarily disabled by low back pain. And the percentage of working age people who admit to having back pain symptoms each year is 50%. So the take home message after all those slides is that low back pain is a major healthcare problem. Take point number 2. And I'll just go to the bottom. The virtually 90% of those with back pain will return to work in less than 6 weeks. Okay, what does that mean? It means that in most instances, low back pain is not an anatomical issue of bones or the vertebrae. It's usually poor use, whether it's a worker who lifted improperly, someone who decided to move their air conditioner and install their air conditioner and is suffering. So most of the time it's a self-limiting problem, but there are those for whom the 6 weeks become chronic, and those, I believe, are the individuals who will benefit most from the Alexander technique because they continue to have what I've learned from the Alexander community, bad use. I don't use that term myself, but who continue to injure themselves because they don't use their bodies properly. It is, in a sense, a repetitive injury. And so here too, low back pain is almost, and I repeat it, is almost always a benign self-limiting problem related to poor use. Now, I threw this in because, as I said in the beginning, I think a lot of, and there's another slide a little further on that where I summarize this in a different way. But of all the back pain, and I'm going to start now, least frequent causes. So about 1% or less of all these millions of people who have back pain, 1% have serious conditions, whether it's a tumor, an infection, some sort of arthritis, which actually can be helped. I've seen it helped with the Alexander techniques, or Paget's disease, which is actually doesn't exist very much today. But so true disease that needs to be one needs to be alerted to that is not related to back pain is rare, as is visceral disease. Visceral disease, by that we mean or disease related to the organs. So in my book, I talk about a man who they couldn't figure out what was the matter with his, he had back pain or mid-thoracic pain all the time. And I don't know what made, I know why I thought of it, because I had kidney stones. So, and I said, you know, the location of that pain, it may not be coming from your back, it may be coming from your kidneys. And lo and behold, we did a CAT scan and he had kidney stones. And once they got the kidney stones out, his back pain disappeared. So, so nephrolithiasis is a fancy word for kidney stones. So sometimes back pain is a result of prostatitis, in women endometriosis, kidney stones, very rarely aortic aneurysms, and sometimes non-mechanical, and and sometimes issues related to the GI tract, pancreatitis, colitis, etc. But to get back to the main issue is that 97% of back pain is mechanical. And I will review what the mechanical, or what we call today, what are the pain generators? What does cause back pain? There are only half a dozen such things that we usually classify as pain generators. And of those pain generators, and let me just quickly throw them out. It could be disc, it could be the joints, because we will see that if you haven't looked at a skeleton very recently, you'll notice that every one of the levels of the spine has a joint, and that's a common. But the most common cause of low back pain is lumbar strain. So of the 70% of the 97% of patients, it's lumbar strain, which is, in my opinion, the most common cause of low back pain, and ipso facto, the diagnosis most readily treated by the Alexander technique. All right, I think I repeated this. I'll just go on. Now, again, the things that you want to, if you see a patient with low back pain, you want to make sure that they haven't had any significant trauma, like a motor vehicle accident. I will review in a subsequent slide what we call the red signs, the signs that alert you that there's a real problem, which include loss of motor strength, obviously, numbness, loss of sensation, or impaired bladder control, unrelenting pain at night, nocturnal pain, a history of cancer, or fever. These are symptoms that are not amenable, usually mean a significant medical problem is going on, or certainly should be ruled out before you decide to have this patient undergo Alexander lessons. Now, as I said, here are the red flags. USAB, let's start with those. That's our little acronym that I teach students, residents. Urinary retention or incontinence. Saddle anesthesia, that means area of anesthesia in the region of the perineum, near the vagina, penis, or rectum. Decreased tone of the anal sphincter or incontinence. And the B, bilateral lower extremity weakness, numbness. So these, if you take anything home today about which patients not to see who have low back pain, it's the USAB patients. Although I share with you, most physicians, like myself, who refer patients to an Alexander technique have already ruled these out. Okay? So, but I would be remiss in not mentioning this since I'm promoting the idea of you treating patients with low back pain. So I would be remiss if I didn't say, be on the alert for these. In addition, patients who are intravenous drug users, who have had a recent infection, or immunocompromised, or have pain at rest. And of course, this is patients who've had a history of cancer. And so that's a lot of information. So I was going to stop here for a few minutes before I go on and see if there are any questions so far. How do we want to do this, with chat or with raising hands? Rebecca, Renee, would you help me out?
There is a question in the chat. They're asking, I wonder if the people reporting low back pain are actually experiencing pain due to SI joint dislocations. What is your opinion on SI joint issues versus low back pain?
All right, so let me go here. Why? Because as I said a few minutes ago, there are just a few places from which pain can originate. That's a complex sentence. From which pain can originate in the spine. One of them happens to be the SI joint. We don't see it well here because here's the sacrum. You don't see the ilium, but this is the SI joint would be here, of course. The others, and I'll give you the most prominent ones, most common ones, and I'll go over them again next. But I want to answer the question, is discogenic disease, here's the disc. Do I need to go over a little bit of anatomy? So there are 5 lumbar vertebrates, L1, 2, 3, 4, 5, and then the sacrum, because the anatomists thought that since babies come from the area of the sacrum, it must be holy, and it was called sacrum for that reason. And between the vertebrae are the discs. Okay, so we all know, people always say, oh, I don't have a herniated disc. But let me get to that in a minute. So this is, if you look at the skeleton, this is called the foramen, Latin word meaning window. And this is where the nerve exits. So the nerve would be coming out at me through that window. And of course, I'll show you a picture in a minute of a herniated disc, where that disc herniation then compresses the nerve as it comes out. But there are other pain generators. One is the joint. Each level of the spine has a joint, and it's a joint that has a an articulating process, just like the joint in your fingers or in your hips or in your knees. It has a smooth surface, so the joint can move smoothly with synovial fluid. But sometimes these joints get arthritic, and the bone rubs against bone. So that's a source of pain. So we said this herniation or degeneration, and I'll show you that also, can cause pain. The disc can herniate, press against the nerve, cause pain. The joint can cause pain. And as the questionnaire, the person who posed the question said, the SI joint can also cause pain. And I'll get to that in a minute. But if we look at a cross section of this area, this is the posterior, is the spinous process. If you put your hand on your back, you can feel your spinous process. But this is a cross section, so you see the body of the vertebrae, and here's the spinal canal. Okay, it's actually, this is wrong. It's not the foramen, it's the canal. And the nerves are in this canal, and then at each level, a nerve exits. So a common problem, and actually I had it, was spinal stenosis, where this canal becomes so arthritic with time that the nerves are actually compressed, and you get severe back pain and leg pain. So those are the primary pain generators, okay? In my book, I mention each one of these primary pain generators, including, and I'll show you a picture in a minute, of the very complex ligamentous and tendinous structures that keep the spine together. But I didn't mention, and this is a response to the question, I did not mention SI joint pain. And that is because an awareness of SI joint pain has only come about in the last few years, and it's a very, very difficult diagnosis to make. And really the only way to truly make the diagnosis of SI joint pain is to put some Novocaine into the SI joint, which is challenging. And if the patient gets relief, you can infer that the patient had SI joint pain, okay? And the same thing is true usually of the joints. So if I think a patient has pain coming from the joints, I'll I don't do it myself, I'll have someone inject the joint, and if the patient gets better, it usually means that it's a painful joint. Now, which one of these do I think is amenable to someone getting a series of 10, and I say 10 because 1 or 2 usually is not going to do it, 10 Alexander lessons? Well, number one, if the person has, most times, if you get pain from the articular surface of the SI joint, it means you have what Alexander teachers would call, and we call it also, poor alignment, right? You are sitting incorrectly, you're standing incorrectly, you're doing your work incorrectly, and you're putting stress on the articular joint of the spine. And every level has two, right? Do I think even disc degeneration, which causes pain because this bone is now closer to that bone because this is degenerate, is also, in my experience, amenable to the Alexander technique. Again, because with proper alignment, proper posture, these bones will then separate a little bit, and the pain can be significantly reduced. So do I think that someone, if they have a large herniated disc and they have significant pain, do I think that person is going to respond to the Alexander technique? Probably not. Do I think someone who has significant spinal stenosis, even someone like myself who has an in-house Alexander teacher, did not respond to the Alexander technique because there's no way that this opening is going to, this canal is going to open with an Alexander technique. I just needed to have this surgically opened so that my nerves were freed. So I'm not saying that the Alexander technique is a remedy for every sort of back pain, but as I'm trying to point out, it's a remedy. And I'm even reluctant to use that word because remedy has, connotations that I don't like. But as a treatment, truly a treatment, the same as Feldenkrais, the same as chiropractic, the same as Pilates, has a same role in the pantheon in the treatment of lumbar disease. And I'm not even talking about neck pain. I'm talking about lumbar pain, as do the others. I get a little emotional sometimes here, I guess. So, and as we alluded to before, the most common cause of back pain, in my opinion, is almost always some sort of ligamentous strain. And what we don't stress, even to medical students, is the complex ligamentous structures that keep us together, particularly in our low back, right? So here's a joint, but take a look at all these ligaments that by the way, the SI joint is here. You don't see it here. You see the SI ligament covering it. So a lot. You can see the SI joint. Just make it out here. You're all going to have to go back to your anatomy book to familiarize yourselves with this again. But ligamentous pain, or we call it ligamentous strain or back pain strain, is usually, again, related to poor use, which is related to some sort of persistent, repetitive injury to the lumbar spine, which, in my opinion, and with my patients, you see it again here, and with my patients has been incredibly well treated with the Alexander technique. I'm not going to go over herniated discs, but I'm going to stop and say a few things here. What time is it? I still have time. Number one, and no slide is going to show this adequately, and that is, one can have a patient who you know, or I know, I'm going to send this person for an Alexander lesson, or lessons, a series of lessons, because I know that their underlying pain problem is amenable to the Alexander technique. And then I find out two things. One, they went once and didn't go again. Or two, they weren't really, and maybe it's the same thing, they weren't really committed. Because, and whether it's the Alexander technique or anything else that I prescribe to patients, if you really need to select the patient that is committed to really getting better. And that is something that we all learn. And I'm sure you've always had Alexander students who don't come back for a variety of other reasons. But in order to get from this to this, it's not going to happen overnight. You really need to be able to, after a while, you get a sixth sense about which individuals, which patients are going to stick to it. I don't know if there's a better word, are just going to stick to it and get better. So it's a double-edged sword. It's you as the Alexander teacher feeling comfortable treating a patient or a student with the Alexander technique, that you feel comfortable enough knowing that this person doesn't have an underlying condition that is dangerous or even harmful, number one. Number two, that you feel comfortable enough with the anatomy, that you have a sense of which one of the pain generators may be causing this individual's pain. And I always point out, even to my medical students or my residents, if you don't know, ask, right? So I know I'm going to use Judy as an example. I know how many times people call Judy up and say, I have this client or this patient, this student, and it has this and this and this. What do you think? What should I do? What modality should I use? And I'm not looking to give Judy more work, but reach out. You'll get my email at the end. Reach out to me if you think. At one point, I had some case studies of patients, again, students or individuals, who we felt did well, and others who didn't do well. And we analyzed why they did or did not do well. So it's good patient selection, both on the part of the person who refers you the client, and feeling comfortable enough to treat that patient, and knowing that if the patient or the individual, the client, is not getting better, that you step back for a moment and say, hey, there's something else going on, or let me ask someone else who may have more experience. And I think those are essentially, for me, the take-home messages, so that some of you may recognize the gentleman on the left, my friend Michael Gelb, so that ultimately you have this fellow here, probably looked a lot like me when I was 50, starting to run with some fluidity. The final take-home message is that the Alexander technique can assume a major role in the treatment and prevention of a major healthcare problem. And I'm going to stop there. I know I didn't use all my time, which is fine, except to point out again that this is a Scientific American this is a cover of Scientific American from 1988. So there's been progress made in the treatment of low back pain, but not much. And I think that nowadays 1998, CAT scans just came into existence. MRI was a dream. And so the diagnosis has improved dramatically, but the diagnosis has improved dramatically primarily for surgically treatable problems related to back pain. It has not advanced significantly in the non-surgical treatment of low back pain, particularly since most low back pain, and I'll say this again because this is so important, is related to musculoskeletal issues that are related to mis or disuse. And I'll stop there and be happy to take any and all questions.
Hi, Jack. I'm not sure if this is a question or a comment. Maybe Kelly can clarify. But she writes, my diagnosis was thoracic outlet syndrome before compressed C5 and C6 discs were identified in the MRI. In fact, non-productive muscle tension, poor use, was contributing factor and probably causing the compressed discs. And the compressed disc resulted in no symptoms. I don't know if you have any thoughts about that. Kelly, you can
What she's
clarify.
talking about is a problem in the cervical spine, not the lumbar spine. So I don't want to confuse people further. Thoracic outlet syndrome is where a blood vessel is compressed that then leads to lack of blood supply to the arm, and it has numbness and tingling. So people think it may be a herniated disc. Fortunately, it's not misdiagnosed too often today because we have MRI angiography. You don't have to inject dye into people anymore and do an angiogram. You can do an MRI. So I find that used to be a common diagnosis that was confusing. I don't think that's so much anymore. And again, it's not an issue of the lumbar spine. It's really an issue of the cervical spine.
Thank you. It was a comment identifying commonalities between what you were stating and my primary issue happens to be the neck rather than lower back, although what you said very much resonated. I very much appreciate what you had to say. Thank you.
You're welcome.
And then there's a question. Someone had kidney stones recently with an infection. The infection is gone, but how long might they have residual back pain?
It's actually a urological problem issue, but someone who's had kidney stones, once the kidney stones passed, there was some soreness, of course, in the urethra because the stone went through, and I was uncomfortable for maybe 10 days or 2 weeks. And but for someone who has that issue, I would recommend talking to their physician about using a non-steroidal anti-inflammatory. They're highly, highly effective, even short-term, in relieving that pain syndrome.
Great. Someone asks, if you have someone who is already being seen by a doctor and they want to try parallel Alexander technique, do you think this would be fine?
You're asking me. Of course, for me, it's fine. That's the whole point. And I think in general, when I started years ago and got involved, Judy and I ran, I think, what was the first holistic health center hospital-based in the United States. And the things that were most disconcerting was the reluctance of the medical community to even entertain the possibility that there were other methods to deal with low back pain. That was a common example. Things have changed, and they've changed for two reasons. One, today medical students are taught in medical school. Columbia, even here, there are courses in alternative and holistic methods taught as to undergraduate medical students. Number two, and I say this a little bit cynically, is that because doctors are spending so little time with their patients, and they know that for the most part, back pain is not going to cause is not the result of a significant illness, they're more than happy to refer those people out to PT, Alexander, Cairo, and because they know they don't have to, they don't have time to deal with it. And it's like the dinosaur in the room. I don't think that's, or the bear in the room, some animal in the room. But that's the truth. And I see that doctors are much, much, much more willing to send patients, their patients, your clients, your students for Alexander, as long as they know that there's an Alexander teacher in the community who wants to see them. I had a very wonderful professor, world famous neuroanatomist, who started his book is the prologue to the book says, you can lead a horse to water if you know the way. And so you as the physician, you have to educate the physician so they know the way, so they know that there's an Alexander teacher in their community who is willing and able to care for individuals with back pain and do so in conjunction with them. So that's a long-winded answer saying that, yeah, I see doctors are more than willing to send, at least in this community, it's a pretty savvy community, but to send their patients to members of the Alexander community who want to see patients with low back pain.
There's a sort of a related question. They say, I assume the way we speak to doctors about the beliefs of Alexander technique for low back pain would make a big difference. Do you have advice for speaking, reaching out to doctors about patients suffering from back pain?
I think get a copy of the British Medical Journal article. I mean, that's their equivalent of the New England Journal of Medicine. That's not some, crazy journal. This is the premier British journal, peer reviewed. I mean, if a physician doesn't get the idea from that article, they're not going to get the idea from anything. So what I say to Alexander teachers is, and that's why I started with it, look at the medical literature. It's there. If you need the references, contact me. I'll send you the references. But the literature is there. And I haven't even kept up with the literature about Alexander technique and Parkinsonism, Alexander technique with movement disorders. There's a really interesting body of work, particularly with Parkinsonism, in the Alexander technique. And those are folks that are looking for somebody to help them. So there are so many opportunities for Alexander technique Alexander teachers to interdigitate, to cross pollinate with the medical community in so many interesting areas.
Someone asks if they have a student who has one of these red flag symptoms, what would the AT teacher do next? Just recommend them to see a doctor?
You bet. Stop right there.
Stop working with them.
Yeah, and say, who's your doctor? I'm going to call the doctor myself. You have to be very proactive if you think that's the case. And if they don't want to see a doctor, you mustn't see them. You mustn't see them. It's malpractice. And I say the same thing to young physicians, or sometimes older physicians who have forgotten a little bit of their medicine. No, don't see them, and make sure that they or you contacted a physician with them.
Great. Can you talk a little bit about the anatomy of the weight delivery of the spine onto the pelvis? And does the pelvis deliver any weight to the side of the sacrum?
So that's a very difficult question. I'm not an expert in biomechanics, and some of that biomechanics has actually not been studied. So I really don't feel proficient enough to answer that with any authority, which has not stopped me in the past, but I'm not gonna. We know that the lowest lumbar vertebrae to S1 obviously absorb the greatest impact And that's why they're the first to degenerate or herniate. L4-5, L5S1 are 90+% of all the disc herniations and degenerations. In most instances, the ligamentous structure around the pelvis is so strong that if you ever took a cadaveric pelvis and tried to separate the SI joint, you couldn't do that. So I don't know enough about the relationship of the sacrum to the vertebrae to answer that well.
Okay. There are many
I'm more curious why the question was asked. I mean.
Hi, that was me, Jack. Thank you. Because recently I was just looking at a picture again of the anatomy, and it sort of struck me as it hadn't ever struck me before of the pelvis. It just looked to me almost like the pelvis not only was the spine, kind of resting inside the pelvis, but it looked like the pelvis was also kind of hanging on the spine. Of course, I was just looking at a static picture of bones and without any other parts, right? So I didn't want to mislead my students, but I just thought it was an interesting way to look at it as both, the pelvis being a structure of weight bearing and as well as hanging on so there was this dynamic.
Yeah, it's like a string holding a bucket at the end. That's how you visualize. I mean,
that's how it looks.
It's interesting. Frankly, I've never looked at
it. Yeah.
Could I add to that? Because I would say that if you want to think about it as a weight bearing structure, and so pelvis. Yeah, the pelvis weight bears, and it's supported from the floor up. So it isn't dangling in any way, not in any way. And when people have, my experience with SI joint is that it happens with people who are particularly flexible. So they're self-selected as dancers and movers because they can move. But the SI joint can often be strained. And unless the muscles surrounding a ligament are there to support it, it can be a problem. But it's not a common problem except among dancers and movers.
Right. No, we were looking at more, I think, how does the structure allow for movement?
It's well designed for movement. You watch Marilyn Monroe walk, the pelvis moves in walking.
Yeah, I do think there could be, because if we think only of the pelvis as bearing weight it could imply greater compression and downward stuckness, right? So I don't know. I just also remember a workshop, and I can't remember who it was, who described the pelvis, like evolutionarily sort of developed as we came from four-legged creatures, that the pelvis is actually sort of a more integral part of the leg, rather than thinking of the pelvis as like an extension of the base of the spine. Anyway, it was more of an exploration, and I wanted to just get an expert's take on it.
Okay.
I think that these ligamentous structures that keep the sacrum together, I think the primary function is during childbirth. And because there's a natural tendency, and the sacrum does expand during childbirth because of this natural outpouring of steroids during pregnancy. Those ligamentous structures actually give a little bit. And every once in a while, I'll see a woman who still has pain after childbirth, and we inject the SI joint or the ligamentous structures around, the pain goes away. So I think a lot of it in terms of evolution has to do with being able to, and that's why women also have a bigger pelvis. I mean, anatomically have a bigger pelvis in order to childbear.
There's a question. Would you comment on the balance of Alexander technique and physical therapy or other complementary alternative modality techniques for low back pain? Are some more complementary than others, or is there an optimal order of practice / treatment?
That's a great question. And it's one that I have to deal with all the time. So and it depends a lot on the person. And there are some folks I know, they are not going to, they want a quick fix. And they're going to do better, I think, with a physical therapist where they're lifting and stretching and bending and, all that kind of stuff. And of course, many times I also see them back in the office because the therapist, with due respect to, also my wife was also a physical therapist, but has pushed them so far because they take pride in how well their clients are doing that they're back in my office. So it's an interesting question. So I usually try to use my sixth sense after these years and try to decide based on the individual, based on if I think, for example, that they've developed atrophy, weakness from atrophy, then I think physical therapy is probably going to be more appropriate at this time than Alexander, because we have to get back muscle mass. I also think that, again, it takes more of an intellect. Maybe that's not the right word, but it takes more of an intellect and self on the part of the person. And by that, I also mean greater self-awareness to benefit from the Alexander technique than physical therapy or even Pilates. And
Can I add something here? Because as a physical therapist, I have connection in the community with other physical therapists, and there are a lot of questions in the chat about how to talk to medical professionals about the Alexander technique. And I have found some of the best people to talk to are physical therapists. They're very interested in collaborating. And I often would see have an Alexander student who was also doing physical therapy simultaneously. And it's a really great combination. So I would say that rather than talking to doctors, that physical therapists are a natural connection for Alexander teachers in terms of collaboration and patient referral, both back and forth.
Thank you.
Could you talk about back muscle spasms?
Yes. So I knew really a lot about it. I'd probably figure out how to treat my own. Judy's laughing. It's like this. I come home. Can I have an Alexander lesson? I mean, it's killing me. Oh, sorry. I've been in the OR all day. Please, please. No, I'm busy. I'm making dinner. No. It's like any other muscle. It goes into spasm from overuse or misuse. So if I stand there for 8 or 10 hours over I'll use myself in this example, 10 hours over the operating table, even though I can sit sometimes from the microscope. Particularly at my age, my muscles don't have much resilience. And what do? Like you've all experienced that. They go into spasm. So I stretch. I try to stretch. Judy now knows that I'm lying about this, but I'm trying to stretch before and stretch after. I say I do it. I don't really do it, but I try to do it. And that helps. And sometimes I will see patients who'll say to me this, and I've actually experienced this myself once, where they said, I was in so much pain, I couldn't stand up. I couldn't straighten up. And that happened to me once. I don't know why, most times people don't know. My muscles felt like they were cement. And I must have done something the day before or did something during the night, sleeping. So muscle spasm is a major cause of back pain. And learning how to use your body in a more efficient way so you don't stress those muscles is key. When I have a patient like that, obviously I need to do something right away. So I'll sometimes start them on Valium, which is a tremendous muscle relaxant. Most people don't use it for that purpose. Or I'll send them to the pain management guy down the hall and say, would you just inject this person, do some trigger point injections? But muscle spasms is a real significant problem. And again, I'm going to say, I think it's a great place for, not perhaps in the acute phase, but in the subacute and chronic phase for Alexander lessons.
Great. We have a question. Can the Alexander technique ever cause harm, even if it doesn't help?
Well, those are two different. I can't imagine how an Alexander lesson could cause harm. I mean, anything's possible, but I don't see it. And perhaps the only harm is the issue I raised. We give an Alexander lesson with someone who has one of the red warning signs. But a lesson in and of itself, I can't imagine causes harm. I mean, it's one of the most pleasurable things there is when you get a great Alexander lesson. You feel like you're floating. Your muscles are all, you feel open and wide, and your muscles feel loose, and you feel that you can, I don't know, run a marathon. I mean, I'm exaggerating, but you feel like you're a different person. You suddenly, oh my God, I'm so much taller. No, I can't see it doing any harm.
Could you comment on patients who have had fusion in the lumbar region in relation to Alexander technique?
Yeah, I was waiting for that question. So very well, for whatever reason, that if this individual is fused, they have lost mobility. How could they not if they're fused? I always think of I always think of it as having some mobility based on non-fusion. If you really, it's like the metaphor is an exaggeration, but it's a little bit like a slinky. So L5, L4, L3, L2, each has a few degrees of mobility. It's much more in the cervical spine, much more. So if this individual already comes in having lost, depends how many levels are fused. It's very hard to treat them because they're not going to regain their mobility. And if I'm walking in the street, I can usually tell if someone's fused. They're walking, I can even usually guess how many levels are fused. There's some people walking around like robots because some idiot fused them from T12 to S2. So they're a challenging group of people, and I think there you really have to ask first, what are you trying to accomplish with these people? After all, any treatment, and maybe I didn't stress this enough, any treatment should have a goal. What's your treatment goal? And can you get these folks more mobile? Probably. Can you get them to relax so that they can use your body? They can use your bodies in a more functional way? Probably. But you're never going to give them more mobility than the mobility that they normally had because they're fused. It's so I hope that answers the question. It's very challenging, even for a physical therapist, for me. See a patient who's already been fused. You don't want to fuse them more, etc. So
can I comment on that, since I'm recently fused, but at a higher level? For those of you who don't know, I had a fusion from C5 to T6 about a year ago after an accident. And I would just say that the best thing that ever happened to me after my fusion was the hands-on work that my colleagues gave me as I was recovering. And so whatever mobility there is subtle, but it's definitely there and it's definitely improving. And there's no reason with someone with a fusion to not have Alexander lessons. You just never know what kind of mobility is possible. And for me, it was a godsend. So, there are people on this call like Kim Jesser, who actually came to see me in the hospital and in my rehab, and it was amazing. So I would encourage you to explore and not be put off by someone who's had a fusion.
Yeah, we're an all-encompassing family. We insist upon having spine surgery, and Alexander lessons. So we cover it all. So it's like that.
We have a couple minutes left. But I'm going to try to get to the rest of the questions. Can you talk about what happens with AT and scoliosis?
Well, so some of the earlier studies actually done by, I think she mentions in the book, Ending Back Pain, right, Jude's? There were some early studies that showed that young women, because it is in back trouble, yeah. And there's some really good pictures in there, actually, of young women. It's almost always young women, that if given Alexander lessons early enough, that you can prevent the curve from extending. And maybe Alexander lessons and a brace. And I think, and I know that there are still practitioners, Alexander practitioners, who see young women like that. So clearly, once the angle has been developed, you're not going to get it back. I mean, Alexander, nothing is going to get it back except surgery. But for young adolescent women, usually in the period of their greatest growth spurt, I think I would certainly try it. If I had a daughter or granddaughter who the school doctor said, I think she's developing a curve, I would say, I would get her Alexander lessons and maybe talk to an orthopedic, pediatric orthopedic person about getting a brace. And the data shows, I mean, I don't do scoliosis surgery, but the data shows that when caught early enough, Alexander technique plus or minus a brace is very helpful and might be able to prevent that person from having surgery, because once you have the surgery, it is a big deal.
Do you have any precautions for working with Guillain-Barré syndrome?
There's no Guillain-Barré syndrome is a syndrome. It's called transverse myelitis. We don't know exactly what causes it. It's usually some sort of, there's usually a prodrome. The person has a viral infection sometime a week or so before, and suddenly they become paralyzed from whatever area is affected down. And can imagine how scary that is. And so there is no treatment for Guillain-Barré. Not that we know of. Plasmapheresis, a whole bunch of things have been tried. I've been involved in one of those trials. But I would say that in the recovery period, let me also say that almost all those folks improve. They get back almost all function, at least hopefully. I mean, and the younger folks are more likely to get back most of their function. It's a devastating problem. But I would say that early on in the recovery phase, Alexander technique and physical therapy would be a great combination. I know of no study that's ever looked at that, but intuitively, I would say that it's probably certainly worth trying. I would also add in general that, and I don't want to piss off physical therapists, but in general, I find that the physical therapists are more interested in strength and flexibility. What I perceive from the Alexander technique, in addition, is an increase in my proprioceptive sense. And to me, that is one of the hallmarks of the Alexander technique. That's why I said before, it requires somebody who's willing, who has some self-awareness. And I have very little body self-awareness. I'm first to admit that. But I've had increased body self-awareness since taking Alexander lessons for so many years, where I don't really know where my foot is in space, but the Alexander technique makes me aware of that. I have to think about it. I have to think where my head is in relationship to my spine and my torso and my pelvis. that's why I think that the Alexander technique is helpful in things, in diseases like possibly Guillain-Barré, certainly in Parkinsonism, and even in pain. If you don't have an awareness of which position relieves your pain or causes your pain, we don't have a chance. But if you have enough self-awareness, and most of us, thank goodness, do, then the Alexander technique adds that interesting piece that the other modalities, chiropractic doesn't do it, Feldenkrais doesn't do it, Pilates does it a little bit, having had some Pilates lessons, I think does it a little bit. But that, I think, to me, when I think of Alexander, I think of proprioception.
I had a question. I had a client who had post-polio syndrome, and her spine was pretty debilitated. I mean, it looked like severe scoliosis. I was wondering if you had any thoughts about working with people. It's almost like they're so fearful of letting go because that reminds them that they have post-polio syndrome.
Right.
So it was kind of difficult to navigate that.
Yeah, it's true. So we have a friend who was chairman of the neurology department here in New York, very prominent neurologist. And I've known him since I was a student. And he always had an altered gait because I've had polio as a child. And then he's in his early 80s today, because he's maybe older. He developed post-polio syndrome. And his wife, who's a neuroscientist, and actually did some research with Judy, takes Alexander lessons and has for years. And he had some Alexander lessons. And I think, if you ask him, he would say it helped. So the other thing about post-polio syndrome is it's so varied. One person's symptoms are so different than another, or clinically they vary so little. It's hard to come to a conclusion about whether it's effective or not effective. And that's why even when it comes to low back pain, I think of low back pain as a garbage diagnosis. What do you mean? Well, because it's not specific. That's why I went through the pain generators. I have belly pain. Well, maybe you have gas. God forbid you've got gastric cancer. The same thing true as low back pain. You have to define where the pain generator is. And once you define it, then you have got a better chance of treating it. Now, most physicians don't have to think about it as intensely as that, because take 2 pills and call me in the morning, right? That mentality. Or call me in 10 days because they know the pain's going to be gone. But low back pain I really dislike that term, but there's no other term. But you have to think more of what's causing the back pain. And is that diagnosis, if you can make a diagnosis, then amenable to the Alexander technique? And that's why I went through the skeleton and said, yes, this one might be amenable, this may not be amenable, the stenosis probably won't, et cetera, et cetera.
Thank you so much. We've actually run over time.
My pleasure. So much fun.
And, on behalf of the committee, we want to thank you and Judy so much. It's been just
it's a great cause. This is a great cause. So I wish you lots of luck. And those who want to contact me personally, I have a very complicated email address, very complicated. It's jacksternmd@gmail.com. Even I can remember that. So don't hesitate to contact me. Sometimes I don't answer it for a day or two because I'm swamped, but I'll be happy to dialogue with anybody. Not anybody, but an intelligent question. All right, guys, I got to go see patients.
Thank you, Jack.
Look for an email from us in a couple of days. We'll send the video for today's recording, and we'll also send Jack's email address in that email. Okay?
Wonderful.
guys.
Thank you.
Bye.
Jack.
Bye-bye.
Bye.
Thank you very much. Bye.